I would like to invite Stephanie Dancer for the last presentation of this section.
Hello everybody, thank you very much Sue for inviting me to speak in this viper's nest of ventilation engineers, physicists, chemists, architects and design. I am the token medic, or I suspect there might be one or two others in the audience. Delighted to be here. And what I'm going to tell you today is really what happened in my health board in Scotland during the second wave of the pandemic. You'll see the skyline of Glasgow on the screen there, and you'll see also the COVID-19 virus transcending. I think the first realization that there was a real pandemic came a lot earlier than the definition from the World Health Organization. I can remember sitting in the intensive care unit, coffee unit. We'd just done a ward round, and it was the end of the second week of January in 2020. And there was talk about this new respiratory infection which in China, which appeared to be really quite severe, for which there was no known pathogen. And someone's already mentioned the fact that if you forget your history, or you learn from history, but there's another version of that, and that is if you forget your history, you're condemned to repeat it. We'd already had the warning signs with SARS-1, coronavirus, and MERS, another coronavirus. The thing is, when we train as medics, coronaviruses, particularly in the field of microbiology, coronaviruses are no big deal. They cause colds, like rhinoviruses and like the milder versions of adenovirus, and nobody gets too upset about it. So the possibility of a worldwide global pandemic caused by a coronavirus was something that we didn't really grasp right at the beginning. Not only there were signs very early on that this was serious, but in actual fact, some papers were coming out just months after the declaration of the pandemic. And of course, as medics, one of the things we were most worried about was, is this organism going to spread in the hospital? Is it in the hospital air that we breathe? And this paper was actually published 2 or 3 months after the pandemic was declared, showing that not only was the virus in the hospital air, but that it was spreading in the rooms of hospital patients outside the 1 to 2 metre zone, and furthermore that it was viable, as you'll see from the tissue culture inoculation there. Another paper which showed us very clearly that in actual fact the sizes of the aerosol carrying the virus was important, and that they were tiny and generally less than 1 micron. And we already knew from work done by a member of a group of 36 many years ago that virions are actually more likely to be concentrated in the smaller respiratory particles than they are the larger. So we had all this at the time. What was going on in Scotland and indeed in NHS Lanarkshire? Well, there doesn't seem to be a particularly impressive first pandemic break here, which is rates per 100,000 population of COVID, but that was because we didn't have the testing up and running. That came, as you know, very quickly. And you can see the second wave here, a biphasic wave. This biphasic response probably attributed to some of the things that were happening in the population as a whole. You can also see that given that the rates on the same scale are identical, that Lanarkshire didn't fare particularly well during the second pandemic wave, in that we've got higher rates there in both parts, almost both parts of the pandemic wave. So a couple of words about NHS Lanarkshire, which is one of 14 health boards in Scotland, and we're squashed between Edinburgh, as you can see here, and Glasgow, as you can see here. We've got Forth Valley up here, we've got Ayrshire here, and just there is Wishaw Hospital, one of the 3 hospitals in my health board. And already, 29th of October, this came from the Scottish Sun, there were a raft of measures introduced to try to reduce the rate of both community and hospital spread of the virus. So people were being asked to stay at home if they could. The pubs were closed, so was the bingo. That probably gives you an idea of the level of this paper. And organised sport was banned. Indeed, all the indoor sort of types of things that were going on, like church choirs and bowls, etc., were banned. But this was short of a full lockdown. That didn't actually happen until Boxing Day 2020. So a couple of words about NHS Lanarkshire. We're semi-rural. It's important to know, so we can open the windows because the pollution is not too bad. There are 3 very busy acute hospitals. Hare Myers is the smallest at 550 beds. Monklands is next, and Wishaw has 800 beds. And there are functioning 24 hours accident and emergency for all 3 of our hospitals. And each hospital has its own specialist services, in particular paediatric and maternity at Wishaw, along with orthopaedic trauma. So, NHS Lanarkshire, because it was in the central belt, squashed between Edinburgh and Glasgow, experienced very, very high rates of COVID-19 during the pandemic, and indeed that is still the situation. And of course, what happens is when you get a patient with the virus in a hospital, you may or may not know that they have it. Firstly, all our patients were being screened by the time the second wave hit us, but it takes time for the results to come back. And because of the pressure on beds, sometimes patients were placed in wards or bays where there were patients who didn't have it, and we didn't know that they were positive. And you'll be well aware that pre-symptomatic and asymptomatic patients shared a great deal of virus without knowing it. So inevitably there were clusters of infection on our wards, and these were defined as 2 or more patients or staff testing positive for SARS-CoV-2 and linked in time and space. So that was our formal definition of a cluster or an outbreak. So I hope you can see this okay. So this indeed is with the time from the 1st of October along to the end of March, so a 6-month period encompassing that biphasic second pandemic wave. And these are actually clusters, not cases, clusters or outbreaks, which incidentally meant closure. And what I've got here is you can see the pandemic wave there mirrored in the care home closures and clusters in Lanarkshire. We've got about 60, 65 or so care homes. And I've also charted the clusters in our 3 acute hospitals. And you can see they're grumbling along during the first part of the second pandemic wave, and then something happens at one of the hospitals. You can see there's a huge amount of problems going on, and that was in Wishaw, which actually specialises in paediatric and maternity and orthopaedic trauma. So I have to say, this created a huge problem because the hospital was nearly closed just before Christmas, so just before there was a nationwide lockdown. And of course, at that stage, we needed to do something. Now, Wishaw Hospital has 2 floors, and floor 1, it's almost identical, as you can see. There's casualty there. We've got most of the general medicine here. We've got care of the elderly here. Then on the second floor, this is mostly surgery, including orthopaedic. And we've got laboratories, paediatric and maternity, and theatres on the second floor. So that's the layout of this particular hospital. What did we do? Well, in response to any outbreak in a hospital, you convene a committee, which has all sorts of different people on, and you all get together. And in this case, it happened very quickly because the ward closures were such that the whole hospital, 800 beds, was in danger of being closed just before Christmas. Every time that there was a COVID cluster identified, the ward was closed immediately. And it wasn't just one patient and one member of staff. We were into double figures at this point in time. The cleaning had already been upped, and we were cleaning with bleach, which is our normal go-to disinfectant for infectious outbreaks. All the patients were being screened on admission, and we started staff screening, which happened in December. There was universal face masking for everybody and visitor restrictions, and that had continued all the way through. We also had daily surveillance for all the COVID cases, so that a notice came round to all of us in microbiology and infection control, telling us exactly what was going on with the numbers in the care homes and the hospitals and how many clusters there were. We were adhering to the normal droplet precautions which come from the government, which meant that the masks were generally the surgical masks and not the respirator masks, the N93s, etc. And these were for aerosol generating procedures only. I'm not going to go into the definition of aerosol generating unless somebody wants me to, because of course this has created a huge challenge for the hospitals. There was a ward ventilation review. Incidentally, we'd had somebody come round in November from the Institute of Occupational Medicine here in Edinburgh, who'd actually looked at the air changes and a number of the rooms, but we didn't have the results of that at the time. There was also an audit of patient boarding and movement, because the orthopaedic trauma pathway at this hospital was really quite complex, and because so many wards were now closed and there was a lack of beds, patients were in essence, particularly the orthopaedic trauma hospital patients, were being moved all over, and they seemed to be taking the infection with them from floor 1 to floor 2. So, and we sent some strains off for genotyping to see if we got anything other than the standard strain that had been causing trouble all the way through. Well, one of the things we looked at was toilets. Thanks very much, Kath, for showing the toilet. I've been called the toilet lady in the past, and I'm actually quite proud of that. There's so little work done on the infection risks from toilets. I wonder why. But we decided we would focus on the toilets at Wishaw, which are poorly ventilated, to say the least. No windows, doors open to the main corridor or indeed to the main ward, both staff and patient toilets, and zero ventilation. These are all naturally ventilated hospitals in my health board. So we decided we would try and get some lids on the toilets for a start, but Health Protection Scotland said that this wasn't needed. So we didn't get that. But what we were able to do was limit the use of the toilets so that they weren't as heavily used during the staff breaks, etc., as they could be. But I think there's going to be more on toilets when people decide that, in fact, when you look at the modes of transmission of not just COVID, but indeed many other viruses, all the pathways of transmission, virtually all of them come into play in the toilet. So we tried to get everybody to wear face masks. The staff were fine. The staff were compliant. And they also knew how to manage the mask because, of course, mask etiquette is important. They need to be removed after an hour or when they're wet. But getting a sick patient to wear a mask, that was a different thing altogether. And it was impossible to audit. The thing we did, which may have had an impact, was we launched an open the windows policy. This happened after the medical director came to the infection control team, distraught because of the number of deaths that were occurring amongst patients admitted not for COVID, but for other things. Totally distraught. And since I had been benefiting from the group of 36, now I think 38, and engaging in huge email discussions on what the role of the ventilation was and exactly how this virus has been transmitted, I decided to do a little bit of work on whether it would make any difference to get the windows open in our hospitals, and in particular in Wishaw. And I was lucky enough that at the time there'd been a couple of papers published. One Lydia was involved in, which was a quantitative assessment of the risk of airborne transmission, and indeed ECDC regulations, which had compiled a whole load of ventilatory suggestions from all over Europe. And it was the Danish ones that I fixated on, because it seemed to me they were supporting the opening of windows in public places to try to dilute the effect of the virus. So using a back of the envelope and A-level physics from many, many years ago, plus Lydia's help, we actually managed to work out that in your standard 4-bedded bay, if you open the windows 15 minutes, 3 times in each 24-hour period, you will have an effect. Didn't know whether to believe it or not, but we went for it. And in the past 40 years, working in the NHS, I don't think I've ever got a policy through quite so quickly. It took less than 3 weeks to get this policy through. Normally in the NHS, you have to punch your fist through a 30-foot concrete wall to get anything changed. Indeed, it took me 10 years to introduce MSASS screening for clean orthopaedics. So this really was something that we applauded. We even had porters who were, if you like, open window champions, who would open the windows regularly during in the corridors, etc. And in fact, subject to security and subject to fire safety, we managed to comply with this. All 3 hospitals got the windows open in all clinical areas at least 3 times a day for 15 minutes. Any complaints? One consultant obstetrician who told me that she had to remember to bring a cardigan in when she went to the canteen. That was it. So here's a schematic diagram of the outbreaks that we saw at Wishaw. And you can see level 1 here and level 2 here. This was care of the elderly. This was the first one to kick off just in the middle of November there, when it all started to go pear-shaped at Wishaw. This was orthopaedic trauma here. This was post-operative orthopaedics. Some of these outbreaks lasted more than a month and involved double figures of both patients and staff. What happened when we opened the windows? Well, you can see we had 3 outbreaks there after we opened the windows. There's more to this, just hang on in there with me. 40 clusters occurred across all 3 hospitals. I only showed you the data there from Wishaw before the window opening, and then there were just 3 up until the March. So we're looking at the pandemic biphasic second wave from October to March, and we started to get the windows open in the 3rd week of January. Okay, so carrying on. Here's the diagram, the figure I showed you earlier with the clusters on. And what I've done this time is I've added in the temperature, because this is something that's been mentioned so far, but not really explored. Now, Lanarkshire lies higher than both Edinburgh and Glasgow, and we usually see the first ice and snow of winter, and we usually see more severe wintry conditions. Now, the very first sub-zero temperatures occurred just here, the first week of December, which was when old people were falling over and breaking hips, etc., coming into Wishaw, orthopaedic trauma, and so on. There's a story here. You can see also that the biphasic bit coming down from the first wave sort of halted a bit there in the care homes. The care home clusters didn't carry on reducing. And then temperatures came up a little bit, but then dived again the first week in January. And you can see acceleration numbers back up again in the care home clusters, because these are clusters, not cases. And you can see all 3 hospitals, although Wishaw were coming down by then, all 3 hospitals were experiencing clusters. Then the 3rd time we had a week of sub-zero temperatures, once again, the decrease in the care home cluster numbers just pans out a little bit, but we don't have any problems, particularly in the hospitals. There are the 3 outbreaks that occurred after the windows opened, 2 at Wishaw and 1 at Monklands, none at Hare Myers. That was when the windows were actually opened, just there. So, did window opening really have an effect? Could something so simple in a busy, complex hospital have an effect in this health board? Well, the trouble is, you can read the points for, and there were many points for, particularly as in February we experienced the highest numbers of patient admissions altogether, the highest number of patients with COVID coming in altogether, the care homes were full and so on. So there should have been even more numbers of clusters in the hospital. There weren't. But the points against is that cases were already coming down when we finally managed to get the windows open. And that's the biggest problem. Plus, of course, the staff vaccination programme, which involved first-line care workers and indeed first-line staff such as myself. Vaccination had been rolled out from the middle of December. Did that have an effect? Was that the reason why all of a sudden numbers came down? So this is the number of patients this time with hospital-acquired COVID. So this was defined as probable 8 days after admission and definite 15 days after admission. So this little peak just here at Wishaw, just after opening, is still within the 2 weeks. Patients may well have been incubating when the window was open. But you can see straight away that whatever was going on in the community and across Scotland as a whole, numbers certainly came down in all 3 hospitals after window opening. But this, I think, is the real clincher. These are mortality rates. This table shows you the number of people that died for each of the months that we looked at in details at all three hospitals, Hare, Myers, Monklands and Wishaw. Here's October, 5 deaths, and we did the rate according to admissions. Look at the death rates here for all three hospitals, and then look at mortality rates once we got the windows opening. There was an immediate reduction in death rate. And you wonder whether just diluting the air in our poorly ventilated, naturally ventilated hospitals had an effect on severity of COVID. We certainly know as medics that high inoculum of pathogen is more likely to lead to more serious disease. I couldn't get detailed information on mortality rates, but that's just in a schematic form. Looking at the rates, there's January, there's February. Was there any difference in February to October, which was similar? No, except we had more cases of COVID coming into the hospital at that point in time, not less. So, well, I already talked about patients being moved all over the ward, the hospital, because of orthopaedic trauma pathways and lack of beds. Here's where the Wishaw problem kicked off, and you can see that the rate of boarding there was extreme, where we were moving sick patients who'd fallen over, broken a femur, between care of the elderly, orthopaedic holding wards, orthopaedic trauma, and then post-operative, taking COVID with them wherever they went along the hospital. And of course, the rate of boarding was coming down when the window opening happened, but then there was no boarding problems in the other two hospitals. This was actually just Wishaw at the time. So some additional data from that ventilation review I was telling you about. I think, first of all, they identified the SARS-CoV-2 virus from surface swabs and from air samples, mostly taken from our designated COVID wards, of which there were 3 at Wishaw. But what they did find was that the ventilation levels in 5 of the 6 areas that they looked at was inadequate, more than inadequate. Only 1 toilet managed to achieve the appropriate air changes per hour. The other 5 places examined was just a tiny little snapshot of a study done in November at Wishaw, showed that, as indeed we knew, the internal air quality, indoor air quality in our hospitals, and particularly in Wishaw at this time, was extremely poor. So in conclusion, we think the virus came in with our staff. Our staff were living in the community, and there was still community transmission going on. Staff passed it to staff, and this would have happened in the staff rooms. Again, these are internal, no ventilation and no windows. Staff take their masks off to eat and drink. Despite the government recommendations of contact droplet precautions, extra cleaning and surgical masks for everybody, all 3 hospitals experienced clusters, and particularly Wishaw. We think that was due to the orthopaedic trauma pathway, having centralised orthopaedic trauma the year before in our health board. The genotyping confirmed that there was inter and intra-ward transmission, and also confirmed that it wasn't a new variant. So it wasn't anything to do with Alpha and Delta. It was the original variant that had been causing troubles from the beginning, from the outset. We knew that the ventilation capacity was reduced. We also felt that there was a link in the sub-zero temperatures, because that's when old people fall over on the ice and need attention. And we think that might have something to do with it. But we also know that the virus prefers cold weather and survives very well in sub-zero temperatures. Introducing an open the window policy, as simple as it was, may have helped control further clusters in our hospitals. So I've got lots of thanks to give to all my fantastic colleagues in the health board who worked incessantly over and above during the pandemic and are now seriously burnt out, but still working. I also want to say thanks to Public Health Scotland for doing the genotyping. I haven't had time to show you any of that, but it was very interesting. Miranda Lowe, who came and did that little snapshot of a ventilation study for us, just to try and give us a little bit of icing on the cake there. And finally, the wonderful group of 36 aerosol scientists, physicists, ventilation engineers and clinicians who gave us their time, expertise and skill freely and unselfishly throughout the whole of the pandemic, and that work continues. Thank you very much.